thankfulness to George and Onasio, and also to Hellenic Cardiac Society for supporting me for this specific issue of the ESC. So I will discuss this quite a huge and broad issue of risk stratification in patients with chronic coronary syndrome. And as you know, now we have 6 scenarios or 6 entities. So I will try to touch and discuss a little bit almost all of them. First, starting with this, what we have in the guidelines from 2019. And you know that for the risk stratification, we have 3 categories: the low risk, the moderate risk, and the high risk, which is more than 3% of mortality per year. And this higher risk is basically associated with ischemia on functional testing. It can be stress echo or magnetic resonance or SPECT or PET. But also I think there is a place for exercise ECG. There is not too much place anymore for exercise ECG in diagnosis, but I think that it is still very important for risk stratification in patients with known and symptomatic coronary artery disease. There is atherosclerotic burden, of course, and if we have the free vessel disease with proximal stenosis and the left main stenosis, then the patient is considered to be the high risk. And in the guidelines, we have only these cutoff points for FFR and IFR, and we have seen in the previous lecture how important is the combination of functional indexes, so FFR and IFR, FFR and CFR. It is challenging for diagnosis, but it is very important for risk stratification, the combination of the indices. So in the guidelines, we have following. On the first class recommendations is that risk stratification is mandatory on the basis of symptoms and diagnostic testings. We see there is a place for CT angio, we shall see that, and exercise ECG, echo LV function, of course, and this is important. In symptomatic high-risk patient, invasive angiography with functional testing is mandatory. Whereas in mild symptoms, but again, the high-risk patients, again, the invasive angio with functional testing is mandatory because revascularization may improve the symptom. That this is 2019 years, to remind you. So then, what should we take into our consideration is invasive angio for inconclusive or conflicting stress testing. And in mild symptoms and CT angio, there is the stress imaging is in front of the CT angio, and also we may consider echo strain in patients with poor ejection fraction. IVUS for left main may be considered, and we have also learned that there is a correlation between the IVUS and FFR in patients with the left main, and of course only invasive angio for risk stratification is not indicated. So now let's discuss a little bit these recommendations because we have the new studies, and this is the conclusion of this HEMIA study that among patients with stable coronary artery disease, so it is belonging more or less into the first scenario, and moderate or severe ischemia, there is no evidence that an initial invasive strategy as compared with the initial conservative strategy reduces the risk of ischemic cardiovascular events over a median period of 3.2 years. And here are the results, and by the absolute numbers, there is more patients with the primary outcome in conservative group, but this difference did not reach statistical significance. So a little bit about the patient population, because I think that this is the clue to understand the results of ischemia trial, because there were 8,500 patients in 5,000 centers. Actually, it was initially 8,500 patients were enrolled in the study, and a little bit more than 5,000 under randomization in 320 sites. So it means if we divide this number, there were 10 to 15 patients per center per 3 to 5 years. So it is 1 to 2 or 2 to 3 patients per year per center. So it is a very rare patients actually. The other point, which is not what we see in Serbia at least, is the initial LDL 2.2 and the final LDL, which is 1.7, which is really very well controlled LDL, at least in this study. So there was a number of patients with previous myocardial infarction, 20%, with previous PCI, 20%, with known angiography, 37%. So it is 2/3 of the patients that we actually know. So it is, again, there's not the patients that we serve. So those are more the patients belonging to the third and fourth category of the patients after revascularizations. And finally, what is most important is the angina. In this patient population, we had 35 patients without angina in the last 1 month, and additional 44 patients with just a few episodes of angina. So it is almost 80% of patients with very rare angina. So at the same time, we have the other observational trial coming from the Miller and Associates, showing that even the higher number of the patients with suspected chronic coronary syndrome, SPECT imaging, revascularization of moderate to severe ischemia, defined as more than 15%, reduces all-cause mortality. So maybe we can conclude, if I were the reviewer, I would probably ask for this, that the proper conclusion of this ischemia trial might be then that among quite rare patients with stable coronary disease and moderate or severe ischemia and absence or very rare angina and well-controlled LDL, there is no evidence that an initial invasive strategy as compared to initial conservative strategy is better. So another important comment is about the CLARIFY registry. You have alluded to the CLARIFY registry, and it is more than 32,000 patients with stable angina, prospective observational registry, where anginal status was mapped each year in patients without new coronary revascularization or new myocardial infarction, and the effect of 1-year changes in angina status on 5-year outcome was analyzed. So among 22% of the patients who reported angina at baseline, so angina disappeared in many of the patients, or the most of the patients, only after 1 year, 40% of the patients. So compared to patients without angina at the baseline, persistence of angina and occurrence of angina was associated with a higher rate of cardiovascular death on MI. Whereas in patients in whose angina resolved, 40% of them at 1 year with conservative management, they were not at higher risk for cardiovascular death or the MI. So we also had in the last couple of years a few very important big studies, the PROMISE, which compared the CT angina and the functional outcome, and they have found that there was not a significant difference in the clinical outcome between initial CTA and the functional testing, with fewer catheterization and more radiation exposure. We had the SCOT HEART, randomized patients to the standard care or CT angiography plus the standard care, and the use of CT angiography in addition to standard care was associated with a better outcome. And there were more preventive therapies also in this group of patients. And they have also found in the sub-study of the CT angio group that there was a significant difference in the outcome between the patients with characteristics of the vulnerable plaque, with low attenuation plaque burden. And it was interesting that it correlated weakly with the cardiovascular risk score, strongly with the calcium score, and very strongly with the severity of the coronary stenosis. And the low attenuation plaque burden was the strongest predictor of myocardial infarction. And this is also very important combined FFR OCT trial, which explored the hypothesis that in the patients with diabetes, which has a fast processing atherosclerotic process, the identification of vulnerable plaque defined with the TICFA is very important, and they have randomized first the patients to FFR less and more than 0.80, and then in the patients with normal or preserved FFR, they have divided the patients according to the OCT with the TICFA negative and TICFA positive, and there were 25% of the patients with the FFR negative but TICFA positive patients characteristic of the vulnerable plaque, and they have shown that the outcome of the patients with the preserved FFR with no gradient across coronary stenosis, but the vulnerable characteristic of the lesion, the outcome is 5 times worse. So there is evidence on the emerging role of the plaque characteristic on the risk stratification. So now I will move to the patients after revascularizations, and we can find in the guidelines that the risk stratification is recommended in patients with new or worsening symptom levels, preferably using stress imaging, or alternatively, which is surprising, exercise stress ECG. And we know how exercise ECG is challenging to perform in patients after revascularization. And the next issue is invasive coronary angiography finding is recommending for risk stratification in patients with severe coronary artery disease, particularly in the patients refractory to the symptoms. And again, there are not too much data about the role and the value of the FFR and IFR in patients with stenting and in patients following CABG. So these are the data from the Marby group, the meta-analysis on the 29 studies, and they have shown the role of the stress imaging in this group of patients, and that was mostly performed with the myocardial perfusion imaging, and they have found that the patients, most of them were asymptomatic, that the risk of the outcome is worse in the patients with the signs of myocardial ischemia on stress imaging. And it has been also confirmed in the group of, this is a little bit going slowly, in the patient from the study from Pelica, from YES, and they have found that there is a huge difference in the outcome of the patients with abnormal stress echocardiography in comparison to the normal. It was 7 times higher, and it is similar as in the patients without revascularization. So the data on the SPECT and here on the stress echocardiography is the same. So the conclusion is that abnormal stress imaging was associated with an average increase in the risk of the cardiac events. So, however, the predictive value of stress imaging in patients has been confirmed. The role of routine imaging has never been tested and proven. And these findings are concordant with the patients before revascularization and by the guidelines, specifically by the American guidelines. The testing is considered inappropriate within 2 years. So after 2 years, it is recommended on if there are some reasons to perform testing, or in patients with CABG, it is after 5 years. So there is a special, also very important question about the management of the non-culprit lesion. And we know there is almost 50% of the patients coming from the primary PCI. They have other intermediate lesions. And there was a question on the physiologic assessments and the timing of the evaluation of those lesions. And we know from the previous studies that they have shown that there was an improvement in the overall clinical outcome, but not for the mortality. Concerning the FFR, there was a little bit of the change in the, if we measure FFR in the acute settings, and in the follow-up, there is a slight decrease of the value of the FFR, whereas for the IFR, the situation is a little bit different, because here we see that if the acute FFR is less than 0.90, which is considered to be significant, there is a significant number of patients which will move to the normal IFR values if we compare it to the IFR again or the FFR. It is. So this is the comment on the use of the functional invasive indices in the patients with stable angina and in patients with acute coronary syndrome, that these data indicate that among patients with acute coronary syndrome, pressure-based indices alone do not consistently identify the stenosis for which revascularization can be safely deferred, and the previous data have demonstrated that there was a higher rate of myocardial infarction and adverse events in patients with acute coronary syndrome in comparison to the patients with stable angina. This is functioning quite poorly. Let's patch here. Here? Or this one?
No, not this one.
This one. Okay.
A big one.
A big one, okay. So this is the final algorithm for the testing of the patients with the non-culprit lesion. And it is primarily based on the complete trial, which have demonstrated that there was the benefit of the evaluation of the non-culprit lesion on regarding mortality in patients with acute coronary syndrome. So if there is a stenosis of more than 70%, then the PCI is recommended, with still the questions on the optimal timing of the PCI and the drugs used in these patients. On the other hand, if we have the intermediate lesion, which is defined as 50 to 70%, then functional testing is recommended, and the functional testing, of course, is positive, then the PCI is recommended, and if not, the patient is followed on optimal medical therapy. And this is also what we have shown with coronary flow reserve. The team, which is led, Professor Anna Djordjevic-Dikic is led. We have shown that for evaluation of the non-carpet lesion, that we can, if the coronary flow reserve is preserved, if it is more than 2, then the outcome of these patients in the following years is also good. And only to touch a little bit the final and group of the patients with microvascular disease or the coronary epicardial vasospasm, it has been shown that in both men and in women, the presence of microvascular dysfunction without obstructive coronary artery disease is related to the worst outcome. And it has been also shown for the vasospastic angina, which is associated over a long follow-up of more than 7 years with a higher rate of combined MACE. And also we have in the recommendations that it may be considered to perform the transthoracic Doppler of the LED or by magnetic resonance of PET in patients for the assessment for microvascular dysfunction, intracoronary acetylcholine with ECG monitoring in normal coronary arteries to assess microvascular vasospasm. And finally, it should be intracoronary acetylcholine should be considered in normal coronary arteries in patients with clinical picture of epicardial coronary vasospasm. So I would like to conclude that what also is defining the high-risk patient is the clinical profile of the patients with the diabetes. Certainly are the high-risk patients. The anginal status is quite important for evaluation of the patients and risk stratification. The plaque characteristic, as you have seen in the several of the papers, are emerging also as important parameter of the risk stratification and also assessment of microvascular function. Thank you very much.
Thank you, Professor Beleslin, for this excellent presentation. I think risk stratification in daily practice is very important because, as you can see also from the guidelines, even for those having high likelihood of having coronary artery disease, you have to start with non-invasive tests to proceed with optimal medical treatment. And if you have a refractory angina, then to proceed to the cath lab. So in daily practice, we can see very often that GPs or cardiologists immediately with the presence of angina to send them to the cath lab. But as you have seen also from your presentation and your presentation, this is not a solution. Because if we will see the profile of patients with angina, 50% of them are post-PCI patients. Yeah. So microvascular disease is another important issue in this field. So PCI cannot be the solution in all cases. So according to the guidelines, risk stratification, it's very important. And then it's very important also to decide what we're going to do. I know that interventionists are not in favor of ischemia trial, but we have ischemia, currents, Bari-Duty, Orbita, with some control. So many trials, and no one saying that in the ischemia and all other trials, they compare optimal medical treatment with invasive treatment, not optimal medical target. Because if you will see also in ischemia trial, even at the end of the study, in expert centers, less than 60-70% of them had their LDL cholesterol under control, diabetes under control. So I'm afraid that if we will compare optimal medical target with invasive treatment, at the end of the day will be in favor of optimal medical target than invasive.
Excuse me, before you answer.
I agree completely.
He's in the cath lab.
I'm also in the cath lab.
As we know, there are many doubts about ischemia, but all these trials, current ischemia, influence us on how to manage these patients. And we become much more careful on how to manage these patients. And sometimes not use PCI, we defer this and attend the patient after 6 months. After all these trials influence the interventional community.
Yes,
It's
I
true.
agree. I think we have, probably we have now a changing paradigm in treating and dealing with coronary artery disease, because usually in the past there was a coronary stenosis when we detect myocardial ischemia. And then when we detect myocardial ischemia, we send the patients to the PCI or the angio. And if there is anything, we are probably going to revascularization. So now I think that we have another options. So which is, if the patient is well controlled, how are the plaque characteristics? What is the clinical profile of the patients? So the myocardial ischemia may and may not influence the outcome. So that is the major message that I received from these studies. And
so if PCI is the solution, why all of them are receiving after PCI a beta blocker, nitrates, ranolazine, or whatever? If PCI is the solution, should be, no angina.
Yeah, I agree.
I think that in stable coronary disease, PCI is not a solution.
Yeah.
It's not a solution.
Of course.
Acute coronary syndrome is another option.
This is
as
the,
we know.
this is the issue
yes.
for doctors in daily practice to understand that stable coronary artery disease is different than acute coronary syndrome or unstable angina.
Yes, yes, yes. I think that this trial influenced us and
Absolutely,
yes.
Dr. Athanasopoulos.
I have to thank you cordially, Branko, for your contribution, your expertise in both clinical aspects, invasive aspects, and also non-invasive aspects provides you with this capability. I believe that we are still running in the upsloping phase of the S-curve, which is always the model of evolving of medical thinking. Till 2010, the prevalent opinion was that everything was geographically based. That was the concept, and we have to respect it. So we have only 10 years since 2010 when the guideline changed and provided the alternative paradigm of inflammation, of valvular plaque, and so on. So currently, we have to deal with the awareness of the population about the easiness of performing an angiogram, and at the same time, to reassure them that although it is very safe currently to have an angio through the radial access, it is not the case to provide you with the security filter for your outcome. So before performing a radial accessed angio, you have to deal with all these measures that Professor Manolis has stated according to the guidelines. And also in the ischemia trial, which is, well, a trial with pros and cons, it is only a minority of patients who have previously surgically revascularized, so we cannot apply ischemia on CABG patients, first point. Second point, we cannot judge about acute coronary syndromes prognosis because acute coronary syndrome event itself is something which has been a secondary event to the chronic coronary syndrome. It's not an isolated event. So first of all, we have to deal with the chronic coronary syndrome as an entity to deal with it. I believe it's a false concept to say that this lady or this gentleman is with no chronic coronary syndrome because we didn't find anything in stress echo, anything in thallium scintigraphy. They might have atheromatoous burden. So it's a widespread prevalence of atherosclerotic burden in everyone. So we have to start dealing with the patient, with the referred questions, not patients, as potential patients, to treat them properly, and then to apply all the sequelae of approaches according to the guidelines. Of course, with the exception of the revascularized patients. So with these comments, I think I have to add these small comments to your excellent contribution. And of course, I have to wish you the best for your effort to be a successful member of the new ESC Council. Dr. Kafkas has a pivotal role in the Council of the Hellenic Society of Cardiology, and they have supported you. So
yes.
Thank you very much. Thank you very much indeed.
A question. Do you believe that in the coming years we'll be able to have scanners, CT scanners, and have information about in daily practice about the characteristic of plaque?
Yes,
It's important for
yes,
us. Yes.
that is definitely coming from the studies, and it is, I think it is for the, I was not happy, I must confess, 5 or 6 years ago, but for everything we need time to adopt and to accept. And it came from the, I think, primarily from the British cardiologists, which strongly push this with their studies, the CT angio, and the comparison between CT angio and functional testing. So I believe that it is a reality, let's say. I'm not aware of all the technical possibilities and easiness to define the plaque characteristics. I have very little experience with CT angio, and it is, for me, it is much more complex than radial angiography, which everybody can appreciate. On the other hand, the CT angio, especially the characteristics of the plaque, is something that we need experts, and we need to put that into the practice. For example, in Serbia, there is now, we are more and more using and sending the patients to the CT angios, particularly in the patients with low pretest likelihood of coronary artery disease. When we have younger patients, there is some symptoms.
Under 50%.
Absolutely, yes. And when there is a higher probability, then we are sending that to functional imaging testing. We have a strong, for 20 years, since our mentor, Professor Ostojic, built our team with very close connection between invasive and non-invasive cardiologists. We always had this approach of first non-invasive testing and then invasive testing, and George is aware of how we are. On the other hand, there is another hospital. The two big hospitals are in Serbia, which are completely having their opinion based on angiography. They are absolutely, more or less, they're not taking care of Dedinje Cardiovascular Institute. They're absolutely angiography guy. And we have always been this, but now we need to also change a little bit our practice to accept also there is a very interesting this data, and we are about to start, actually we have started a study on in diabetic patients about the comparison between CT angiography approach, functional approach, no testing approach in asymptomatic patients. So I think there is a place, and I agree completely with George that there is that we have increased that we are on the on the increasing part of the slope for this chronic coronary syndrome. And I think that these guidelines were among one of the best guidelines in the couple of years on the chronic coronary disease, because they set the stage for the new improvements and new developments. So I think that there is a lot of studies in front of us, and to define and to stratify the patients in the best way.
And a last comment in your excellent presentation. For an interventional cardiologist, it's very difficult to perform IFR, FFR in the environment of primary PCI.
Yeah.
It's difficult. It's night, it's 12 midnight, you are very tired.
Yes.
Yes.
You're right. Yeah. I mean, we are performing. There is a lot of data about the rate of the performance worldwide, and it is worldwide. It is not more than 10 to 15%.
Yes.
In general population. So I think when you plan to do PCI, then it's a little bit more. Let's go to 40, 50%. So we are having different systems. We are doing IFR, FFR. My practice is to, if the IFR is strongly on one, on the other side, then it is enough. If it is in the gray zone, my practical around 0.89, because the reproducibility of IFR is less than FFR. So you can measure FFR with increasing doses. It's more or less 0.01, 0.02. But with IFR, we need to be a little bit more careful. And but I think it is a nice tool. You don't even to have in the cath lab, because when you do on FFR, then you need additional 5 to 10 minutes to prepare adenosine, whether it is going to intracoronary usually or that. IFR is really simple, but still there is a high financial burden about the IFR and FFR, and and it is, I think, the major issue. If the price of the IFR and FFR would be like a little bit more than the regular wires, it will be used much more. And I think that the only obstacle in the usage of the FFR is the price of the and the quality of the wires. Of course, it is not the superior quality wire.
Thank you very much. Thank you very much. So